So what do we have as evidence? The only IO which has been convincingly demonstrating survival benefit was Atezo in combination with beva in first line. So that's what we have. The monotherapy has not made it into a significant analysis, Nivo in first line and Pembro in second line, but there are other substances still around, so the question about monotherapy, whether it's first or second line, is not yet, the door is not yet closed. The objective response rates, which we have been seeing in both first and second line, are very convincing. So if you benefit from IO therapy, then the likelihood that this is a deep and a durable response is very good, and that can be an aim to go for. And if you ask a group of experts, if you, not as a physician, but as a patient, would suffer from HCC, what would you personally want to get as first-line treatment? Most people will tell you they will get started with an IO. But again, it is not really evidence-based and has not been thoroughly compared. Once we have Atezo and beva approved, it will be in first line. And then it is very clear, it is making a lot of sense then to continue not with another IO, but rather with another IO in combination, or plainly a TKI.
All targeted agents and all immunotherapy, the target population, target patients are Child-Pugh-A so far. But the 040 cohort 5, which is patients with Child-Pugh-B, and that patient subgroup, the response is maybe 6 patients out of 28 or something. I forgot the number, but so 30 patients, yeah, 20 sorafenib treatment patients, and 6 patients was a responder. In other words, 12% response rate, which is not bad in Child-Pugh-B patients, and the tolerability is similar to Child-Pugh-A patients in cohort 040, cohort 1 patients. So disease control rate is also similar, 55%. So that is very good information. There is no systemic, no indication for any targeted therapy or immunotherapy for patients with a Child-Pugh-B patient, but Checkmate 040 cohort 5 clearly showed Child-Pugh-B patients also have a survival benefit. And with similar adverse event with the Child-Pugh-A patients.
So immunotherapy-related toxicities can range from mild and almost trivial in some cases to impactful, life-threatening, and emergent. And so I think that the spectrum of severity is quite dramatic, and really requires immediate attention to detail and close follow-up, even for what seems to be a mild toxicity at the outset, because of its potential to represent something much more serious. So I think that some toxicities like dry skin, dry eyes, itching, mild rashes are managed conservatively quite well with moisturizers, sometimes topical steroids, eye drops for dry eyes, things like that. But other side effects can be much more elusive to determine the etiology, but also can be quite dangerous. So a patient that calls in with a complaint of new fatigue may have quite simply mild new fatigue from therapy, but that should also raise the index of suspicion for something more alarming, such as a new onset endocrinopathy, which could be type 1 diabetes or adrenal insufficiency or hypopituitarism from hypophysitis or inflammation of the pituitary gland. So any new vague symptom that prompts a patient to reach out does have the potential to be something quite alarming. And our practice in the clinic is generally to obtain a broad panel of laboratory testing, including a random cortisol if there is concern for something as vague but potentially serious and life-threatening as adrenal insufficiency, liver function, glucose, electrolytes, renal function, a comprehensive metabolic panel along with some endocrine surveillance in patients with vague or ill-defined symptoms. And to arrange for an in-person or even a video visit, particularly in the era of COVID, when we may have restricted our in-person visits in some locations, to lay eyes on the patient and discuss in person their symptoms within a short period of time. Now, in severe immune-mediated toxicity, patients will require immunosuppressive therapy, such as high-dose steroids, which sometimes can even require inpatient hospitalization depending on the severity of the inflammation, such as a colitis or enteritis, may require IV fluids or inpatient endoscopy evaluation or a liver biopsy if it's a hepatic adverse event. And so, again, depending on the results of the initial evaluation, a patient will require downstream treatment, and the treatment itself may require pretty intensive monitoring in the case, for example, of high-dose steroids or immunosuppressive regimens beyond steroids.